Good evening or good evening. Welcome to Online Dentistry. Yet again, once again, the free webinar. Just give us a couple of minutes more time. We will be starting pretty soon. Once the Zoom is stabilized, we will be starting soon. Just give us 2 to 3 minutes time. During that time, make sure that you can hear my voice. You can see the slides which I've shared. If everything is fine, you are good to go. You can take a quick break of 2 minutes. We'll be just starting it pretty soon. As you all know, colleges have restarted again, slowly crawling back into normal life. Many places in Kerala we have opened up, and for third years, 1st of July will be the opening dates. Let's hope and pray we all get back into a normal curriculum and carry on with our professional life. So during these times, this is going to be a very quick review of your past third year exam topics. And so once your exams are opened up, this is really going to help you a lot. Just give us a couple of more minutes time. We will be definitely starting the session. Within a minute's time, we'll be starting the session. Kindly give us a couple of minutes time. Yes, Dr. Joe, are you there?
Yes, sir.
Is it everything is ready? Shall we start?
Yes, sir. We have stabilized on both Zoom and YouTube, sir. We can start.
Okay, fine. Good evening, one and all. Welcome to Online Dentistry's yet another free webinar. And today is exam alert exclusive for third years. And that's about oral pathology. That's what we are going to discuss today. So Online Dentistry is a firm dedicated to dental education. We have started this firm around 2008. It was its inception, and we were having offline courses initially. And recently, once the pandemic struck over, we had to suspend all our offline courses and we moved on to online courses. The real name Online Dentistry is under trademark now. It's started with pandemic, which has started recently. Still that time we were all having offline courses, and still we are going to start our offline courses also soon. So this is what we are. We have been in this from 2008 onwards. We have crossed around 20,000 plus dentists across the globe. People from Caribbeans, Australia, US, Singapore, UAE, dentists, and different universities, faculties, everybody under one roof all over the globe, sharing information, educating people. And that's a wonderful feeling during this pandemic time where we felt the dentistry had lost its grip, but we online dentistry hold it together to make this fraternity under one umbrella. Thanks for your support, motivation, inspiration, guidance, and referral. That's how we could grow into this number. Please do that, because this is a one platform. All branch comes and you can learn daily basis. from our website, from our webinars, previous webinars, all those things you'll be able to learn. The CEO, my partner, my friend, Dr. Binuti Abraham, orthodontist, currently practicing in Kerala for the past 22 years, an amazing personality to meet his vision along with us. Together, we started this firm in 2008. I am currently working as a professor and head of the department, Anu Dental College, Pediatric and Preventive Dentistry Department. You are all welcome to our departments any time of your life. Please call us and visit our college and the departments. We have centers across 10 centers with the grace of God and support, which I mentioned you, all are word of mouth, and people started coming up to offer support in each state, and we opened up in 10 states in India with 10 centers across India. But all the centers, the offline courses are suspended, but people are joining from all places across India by the referrals for this online module, which are free modules happening up today. And so many paid modules are also there. So this is our centers across India. We have traveled across the country, outside country, just carrying the knowledge and imparting knowledge to the needy ones there. So all the offline courses are suspended at this point of time, and you are attending one of the free webinars, which are of online free webinar today you are attending, and more are coming in the coming weeks there. Do not miss all these basic topics if you are going to be a dentist at one period of time. Even if you are now in third year, final year, part one or part two, I have one more year. Please do not miss this webinar. Just be there, listen to it. Next time somebody is going to take a lecture, you will remember online dentistry's lecture. Oh my God, I remember, I know this. So easy to grasp now when you listen the theory part. And it will be a good thing, especially topics like local anesthesia, orthopedic movements, and orthognathic surgery, which are all vague for us during our undergraduate times. This can really change your mind and give you a clear idea which segment of dentistry I have to choose. Where is my passion and talent? You must attend these webinars, and all free webinars are there. And these are some paid webinars. This is exclusive for the practitioners who are into practice. These are a boost to their practice, especially clear aligner is a boost in their practice, especially in this COVID time. It's a big thing that is happening all around. The talk of the town is a clear aligner webinars, because they are searching for this webinar because it can give you income. At the same time, there's no aerosol. It's so easy to manage patients if you get correct guidance. That's one point. Do not get misled by things. You need diagnosis, very important. And this is our webinar. We offer one full day diagnosis, patient management, how to charge the patient, which lab is the best, even lab support are there, T-scan is there, everything modern technology is there for this webinar, this coming up webinar. And this is a one must attend webinar, a free webinar by none other than Aparna Pandya. Ma'am is a well-known speaker, motivator, guidance in the in dentistry, but her passion is the daily life of a dentist as a student, as a professional, as an academician. What are you? She's going to split you open your mind and tell, what are you doing all this time? This is a time to reboot yourself, analyze what is hidden in you, use the time. Please do attend, because she is a trainer for many of the celebrities and high profile people. She is a trainer to stress free, break free from the life and enjoy what are you doing it. So must attend this webinar. And then comes the other session exclusive for 1st of July, Thursday, periodontics, because the exam is also going to come up. Do not miss this periodontics by Dr. Vivek Narayan sir. He is the professor, he's a reader in GDC Kottayam. So do not miss sir's class, are well accepted classes. So you will get a proper guidance on periodontology. And we have the association with the Lincoln University, and the posting is going to come. There is a certificate program coming up on interceptive and preventive orthodontics with Lincoln University, certified from Malaysia, with CDC points, which we get permission, then that will be given to you. So those people who are interested can register for the program that is going to come up. The all things are done. We'll be posting in the group, and you can go to our website and get registered. Those interested can go register. One full day program on crowding, preventive and interceptive orthodontics, and clinical management will be there. And if you are not one of the members of, we get minimum 10 to 15 referrals we get to want to join our exam alert, want to join our professional group of online dentistry. So if you have any friends, seniors, juniors, your best friend, faculties, anybody is there, please send them the numbers. We have separate groups for practitioners, we have group for students. Once you are passed out, you can move on to the professional group where you get guidance. So all those things are well planned. So you can message us, we can add you to the respective groups at this point of time you want to join. All are available in our website also. And to talk about today's topics, Jayanti ma'am, a passionate teacher who spends time in making the subject grasped by the students, like how you listen to a class in your undergraduate, you can say in your first standard, second standard. She specifically tell those words which are difficult for us to understand. That passionate and down to earth the way she teaches, oh man, it's amazing. That's the way that I feel glued to the chair when ma'am take classes, because the way she explains each topic which are so difficult in oral pathology to understand, and she repeats it. And so she is working as a professor in on Department of Oral and Maxillofacial Pathology, Azizia Dental College, Kerala, Kollam. And I welcome ma'am for the second session. Let me stop the share. Ma'am can start sharing the screen. Listen to ma'am with paper and pen, and then you go and read the textbook. Man, it will take you, mesmerize you. Oh man, it's so easy now. I can understand it. These are the points to be written. So with this, let me welcome Jayanti ma'am, and you can start sharing, ma'am, and all the best. Thank you so much for coming in this platform again, ma'am. We are so much privileged to have you again.
Good evening, everyone. Thank you, Dr. Joby, for that kind words of introduction. So without wasting much of time, I think we have a lot to cover. We'll just straight away start with the topic. Today, I was planning to discuss about dermatological diseases. So if you see the standard textbooks, Schaefer or Neville, whichever textbook, or even third year BDS, mastering third year BDS, any textbook you see, this particular topic, is mentioned as dermatological diseases or skin diseases. That's what they mention. But what you need to understand is that most of the diseases that affect the skin, yes, also have oral manifestations. Why this happens is because there is a lot of similarity between the skin and the oral mucosa. Now on this screen, on the left-hand side, what we have is the histology, normal histological picture of skin. So as you can all see, if you're able to appreciate and see my cursor moving, you can see that this is the epithelium of the skin, okay, lining epithelium of the skin, and it is a keratinized. You see on top a pink color area, it is a keratinized stratified squamous epithelium, and below the epithelium, you have the connective tissue. And what is more striking here is within the connective tissue, you see some areas like this here. This is the sebaceous gland. This is the hair follicle. And you also see sweat glands. So these sebaceous glands, sweat glands, and hair follicles, which are exclusively seen in the skin, but not in the oral mucosa, they are called adnexal structures. Whereas when you see the oral mucosa, different areas of oral mucosa have different type of epithelial lining. So you classify them into two groups. If you remember the first year histology, one, you have something called lining mucosa. Lining mucosa is usually covered by non-keratinized epithelium. That's what you see here. That is also stratified squamous epithelium, but it doesn't have the surface keratin. So it is called as non-keratinized stratified squamous epithelium. That is the lining mucosa. So which part of oral cavity has this lining mucosa or non-keratinized epithelium is your floor of the mouth, ventral surface of the tongue, buccal mucosa, then labial mucosa, soft palate. All these areas are lining mucosa. Whereas gingiva and hard palate, these are two areas which are called as, they are masticatory mucosa, which means that when you're eating food, the food comes in contact only with these two areas. Now, next time when you eat food, you can just realize and feel that your food is coming in contact only with, most of the times, only with gingiva and hard palate. That is why these two areas are referred to as masticatory mucosa. And that is histologically lined by keratinized stratified squamous epithelium. So whether it is skin or it is lining mucosa of the oral cavity, or it is masticatory mucosa. Basically, it is stratified squamous epithelium. The word stratified means you have multiple layers. It is not a single layer, but you have multiple layers of epithelium. Strata means layers. So that is why it is called stratified. It's called squamous epithelium because though you have multiple layers and each layer has different type of cells, what type of cells are seen in the superficial aspect on top of the epithelium is flattened squamous cells. That is why it is called stratified squamous epithelium, which means that there are different layers. Each layer has different morphology of cell, but the superficial layer has a flattened appearance. So it is a squamous epithelium. And in oral cavity, lining mucosa is non-keratinized stratified squamous epithelium, whereas gingiva and hard palate, which are actually keratinized mucosa, is lined by keratinized stratified squamous epithelium. And you have two types of keratinization, as you see in the picture here. One is orthokeratinization. The other one is parakeratinization. If you clearly notice here on top, what you see the pink area is keratin. You don't see any nuclei there. You only see a pink keratin there, which is a protein basically that is produced by these epithelial cells. That is orthokeratinized. That is, this keratinized layer will not have any nuclear remnants. Then you call it as orthokeratinized. Whereas if you have to call it parakeratinized, in the keratinized layer, you can see the blue dots there. Those blue dots represent pycnotic nuclei. Pycnotic nuclei means nuclear remnants. They are not complete nuclei. Only a cell will have a nuclei. Here, there is no cell. It is only a keratin protein that is present. But the remnants of the nuclei are seen in this keratin area. That is pycnotic nuclei. If you have a pycnotic nuclei or nuclear remnants in the keratinized area, then you call that as parakeratinized. Okay. So in the oral cavity, you have three types of epithelium. Either it can be orthokeratinized stratified squamous epithelium, parakeratinized stratified squamous epithelium, or non-keratinized stratified squamous epithelium. In contrast, skin has only one type of epithelium throughout. It is always keratinized stratified squamous epithelium. So, and another difference is you have adnexal structures like hair follicle, sebaceous gland, and sweat glands in the skin, which is usually absent in the oral mucosa. Okay. Now, when you see, now we will, from the skin, we will move on and restrict ourselves to the oral mucosa. Now you have the epithelium here. Okay. Below the epithelium, what you see is the connective tissue. The other name for connective tissue is lamina propria. Now these terms, sometimes you get confused with these terms. So the connective tissue of the oral mucosa is otherwise called as lamina propria. Okay. So whenever you have a connective tissue, anywhere in the human body, not only in the oral cavity or skin, anywhere, if you have epithelium, always beneath the epithelium, you will always have connective tissue. Why is that? Because epithelium is avascular. There is no blood vessel in the epithelium. So you can see that only epithelial cells are seen. Therefore, if the epithelial cells need to survive, they need nutrition, they need blood supply. That is always provided by the underlying connective tissue, which has blood vessels. That's the reason why whenever you have epithelium in any part of the body, always that epithelium below that you will have connective tissue, so that the blood vessels in the connective tissue will provide nutrition to the epithelial cells by a process of diffusion. Now, if you have epithelium and below that connective tissue, at the junction of epithelium and connective tissue, this area, junction of epithelium and connective tissue, you have a separating line, separating area that is called basement membrane. Okay, so you have epithelium, below that you have connective tissue. At the junction of epithelium and connective tissue, separating these two structures, you have something called basement membrane. Now, when you have seen a normal oral mucosa, you would have seen a slide of gingiva or hard palate in your first year undergraduation, you would have seen a slide of it. You all would have appreciated the epithelium and connective tissue. How do you see the basement membrane? You just see it as a pink color line, because all these are seen as pink and blue, because the commonly used stain is eosin and hematoxylin. Eosin gives pink color to the tissue, hematoxylin gives kind of blue or purple color to the tissue. Therefore, the basement membrane is usually seen as a pink color line. That's all. But what actually this basement membrane contains, if you have to know about that, you will not be able to appreciate that in a light microscope. So you will go to a higher resolution or higher magnification microscope that's called electron microscope. I think you all know what electron microscope is. Okay. So when you look under the electron microscope, the same oral mucosa, whatever you see here, epithelium, connective tissue, and basement membrane, the same structure, instead of a light microscope, if you look into an electron microscope, what will you see in the place of a basement membrane? What you will see is it's not just a single line, but it is an area. So there you will not use the term basement membrane, you will use the term basal lamina. So when someone tells you basal lamina, do not get confused. It is nothing but the electron microscopic appearance of basement membrane is what you call basal lamina. So what does this basal lamina contain? The basal lamina actually contains three different layers. One on top, close to the epithelium, is called as lamina lucida. The second layer below that is called lamina densa. And the lowermost portion towards the connective tissue is called lamina reticularis. So lamina lucida, lamina densa, lamina reticularis. These are the three parts or three layers of basal lamina, which you will be able to appreciate only when you look under an electron microscopy and not in light microscopy. Okay, so with this basics in mind, because understanding this normal histology and structure of oral mucosa is important for you to understand what can go wrong with this. That's why I took some time and explained. For some of you, it may be a revision of what you already studied in your first year histology, but still, I think it's worth it. So now moving on to the skin diseases or dermatological diseases. More than skin or dermatological diseases, I would personally prefer calling these diseases as mucocutaneous diseases. As the name only suggests, I told that they not only have manifestation on the skin, but they also show manifestation in the oral mucosa. That's why it is better to call them mucocutaneous disease rather than simply calling them as skin or dermatological disease. So you have different etiology for different diseases. Just for simplification, this is not any standard classification, but just for you to understand, I have basically classified the skin disease into three groups. So the entire lesions, what you see in the textbook under this topic, can be classified into any one of these three. The first one is autoimmune skin disease. The second one is, it is immune mediated. That is, some kind of immune abnormality is there, but it is not autoimmune and you don't have specific etiology for that. The exact cause is not known, but you only know that some immune abnormality is causing that disease. That is the second category. And third category is genodermatosis. I'll explain about that later. First, we will go to autoimmune diseases. The majority or the main important questions that are frequently asked in the exam. It can be any university all over India. Very, very frequently repeated question is these autoimmune skin diseases. So I'm going to concentrate more on that autoimmune skin diseases. Okay, now for understanding these autoimmune skin diseases, you need to know some other normal structures that you see in the oral mucosa. I already told you oral mucosa is lined by stratified squamous epithelium. So you have two epithelial cells. Always adjacent two epithelial cells are interconnected with each other. Now, this is one epithelial cell. This is the nucleus. This is the adjacent epithelial cell, and this is the nucleus of that cell. Now, these two adjacent epithelial cells are always interconnected with each other. That interconnecting junction is called as desmosomes. Okay, that applies to all the epithelial cells. That is a unique feature of any epithelial cell, that always adjacent two cells will be attached to each other, and that attachment is by a process called desmosomes. Now, we had different layers of epithelium, right? You have basal layer, spinous layer, granular layer. So you have different layers. Now, the basal layer is what is lying on top of the basement membrane, because the basal layer is the lowermost layer of the epithelium. Then just below that, you have the basement membrane. So now assume that whatever I've shown you is the basal cells. So you will have a basement membrane here. Now, these basal cells of the epithelium are attached to the basement membrane. This yellow line is the basement membrane. So the basal layer is attached to the basement membrane by another type of cell junction that is called hemidesmosome. Please remember, all these are normal structures that is seen in normal people, you and me. If I take the oral mucosa and see, every one of us will have this. It is not anything related to pathology. We are only talking about normal structures. So the adjacent two epithelial cells are connected together by desmosomes. The basal layer of epithelium is attached to the basement membrane by hemidesmosomes. And I already told you that basement membrane is called as basal lamina under electron microscopy. And the basal lamina has three different layers: lamina lucida, lamina densa, and lamina reticularis. Now, the lamina lucida layer is made up of a protein called laminin. Always remember L and L. Lucida contains laminin. Laminin is a protein. Then lamina densa, the second layer, contains type 4 collagen. You have so many different types of collagen. Out of that, type 4 collagen is specifically seen in the lamina densa layer of basal lamina. And lamina reticularis, the third layer, is made up of, again, collagen fibers, which are called anchoring fibrils, which is nothing but type 7 collagen. So lamina lucida is made up of a protein called laminin. Lamina densa contains type 4 collagen, and lamina reticularis contains type 7 collagen, which is also called as anchoring fibrils. Now, what happens in autoimmune diseases is that immune cells and immunity is supposed to work against foreign antigens. That is, suppose a bacteria or virus, something enters our body. Bacteria and virus is not part of our body. Therefore, our body's host defense mechanism will fight against that bacteria and virus and try to remove it out of the body. That's how an immune system works. But in autoimmune disease, what happens is no foreign antigens or microorganism is entering the human system. But the immune cells are getting activated against our own tissues and our own cells. And these cells are getting activated, the immune cells are getting activated, and they start producing antibodies against this self-antigens. Why are they called self-antigens? Because they are not any foreign antigen that is coming from the outer environment, but they are normal cells and tissues and proteins that are seen in the oral cavity, which are being attacked by our immune system. Such type of diseases are called autoimmune diseases. And you all know that antibodies are produced by B lymphocytes. The B lymphocytes will differentiate to plasma cells. Plasma cells produce antibodies in response to any foreign antigen. But in case of autoimmune diseases, these B lymphocytes are getting activated against our own normal proteins and antigens, and they are producing autoantibodies. And these diseases are called autoimmune diseases. So what are these autoimmune diseases? And what are the self-antigens each of these diseases are being targeted? That's what we are going to see. The first disease is Pemphigus. This is a very frequently repeated essay question for you, very, very important. Now, what is Pemphigus? Now, by now you understood that it is an autoimmune disease. It is an autoimmune mucocutaneous disease, which means what? The etiology of this disease is autoimmunity, and it is a disease where you see both lesions on the skin as well as in the oral mucosa. That's why you call it mucocutaneous disease. So I said it's an autoimmune disease, so autoantibodies are produced. Against what? That is the next question. Now I'll go back to the previous slide. I showed you these desmosomes and hemidesmosomes, right? Now, these desmosomes are made up of some proteins. One important protein of desmosome or component of desmosome is called desmoglein. Okay, desmoglein. Now, autoantibodies are formed against desmoglein 1 and 3 in case of Pemphigus. So please understand here, desmoglein is nothing but it is a component of desmosome. What is desmosome? Desmosome is cell-to-cell attachment of the epithelial cell. Okay, so desmoglein is a part of desmosome or is a component of desmosome. So in Pemphigus, autoantibodies are formed against desmoglein. So what will these autoantibodies do? They will destroy the desmoglein. So if desmoglein is destroyed, the desmosome will also be destroyed. So the cell-to-cell attachment will be lost. This process is called acantholysis. So what is the meaning of acantholysis? Loss of cell-to-cell attachment of the epithelial cell is called as acantholysis. This is what is happening in Pemphigus. It is an autoimmune disease where autoantibodies are formed against a normal component, that is desmoglein 1 and 3, which is actually a part of desmosome. Therefore, these autoantibodies will destroy the desmoglein and in turn the desmosome, causing loss of cell-to-cell attachment. This leads to a process called acantholysis. So this is what is happening actually. So clinically, how is this reflected? So what if acantholysis happens? patient will clinically get something called vesicle or bulla. Now, what is this vesicle or bulla? A small fluid-filled blister. A blister is there, but it is filled with fluid. And if it is less than 5 millimeter, you call it vesicle. If the same fluid-filled blister is greater than 5 millimeter, then you call it a bulla. So the basic difference between vesicle and bulla is only the size. Otherwise, both are fluid-filled blisters. So clinically, because of this acantholysis, patient is getting vesicle and bulla. Where do they get vesicle and bulla? On the skin as well as in the oral cavity. So I am showing pictures here of patients with pemphigus, where patient is having vesicle and bulla in the oral cavity. This is in the buccal mucosa, this is in the gingiva. Now what happens in the oral cavity is you're constantly eating food, you're talking, so friction is always happening. Therefore, you don't see an intact vesicle and bulla. This vesicle and bulla will rupture because of the trauma and friction, and the vesicle and bulla will become an ulcer or areas of erosion. So this red area, what you see is nothing but an area of erosion or ulcer. So if you ask history from the patient will be able to tell you that before this red areas, actually there was a fluid-filled blister. That blister broke and then only this erosion formed. So basically, pemphigus is a vesiculobullous lesion clinically. When I'm telling it's a vesiculobullous lesion, I'm talking about the clinical appearance. When I say it is an autoimmune disease, I'm talking about the etiology. So pemphigus is, I'll rephrase it, it's an autoimmune mucocutaneous vesiculobullous lesion. So which means that the etiology is autoimmunity and it is mucocutaneous because it affects both skin and oral mucosa. It's a vesiculobullous lesion because clinically it produces vesicle or bulla on the skin and the oral mucosa. Okay, so that's what you see here. So now what do you do? Next, what do you do? Patient comes to you, there is, areas of erosion, redness. You ask the history. They tell you that, yes, madam, there was a vesicle or a fluid-filled blister that broke and now it is like this. What do you do next? We cannot decide that it is pemphigus because pemphigus is not the only vesiculobullous lesion. There are so many other vesiculobullous lesions that can affect the skin and the oral mucosa. Therefore, what you need to do is the next step, you need to take a biopsy. And histopathologically, what do you see? Histopathologically, what do you see is that this is the, when you take a biopsy, you see epithelium, below epithelium, you see the connective tissue. And if you all can carefully notice, you see that white area, just one white space. So what is this is, there is the same thing only, I have put it in a larger picture, higher magnification. This is the basal layer of the epithelium. Just above the basal layer, you see these empty areas. That's what is seen as the white area here. So what happens here is just above the basal layer, the cell-to-cell attachment is lost. You see the cells here? On top, you see, this is one cell, this is another cell. They both are attached. They are closely placed because the desmosomes and desmogleins are normal here. Whereas in this area, if you carefully see, the cells are freely floating without any cell-to-cell attachment. This is what is called acantholysis. That is, cell-to-cell attachment is lost. These cells are called acantholytic epithelial cells. They have a specific name that's called Zhang cells. I'm pretty sure you all would have heard about it. Zhang cells. So what are Zhang cells? Zhang cells are nothing but acantholytic epithelial cells which are freely floating within the epithelium that you see in pemphigus histopathologically is called as Zhang cells. And specifically, you see that split formation. That is, split formation means that empty area, what you see here, that split formation is just above the basal layer within the epithelium. So that is called as suprabasilar split or intraepithelial split. So clinically, you saw a vesiculobullous lesion, which is histopathologically showing a split. Split means there is an empty area in the epithelium that is specifically located above the basal cells. So it is called suprabasilar or intraepithelial split. In addition to the split, you also see acantholytic Zhang cells. Then you know that you're dealing with pemphigus. Okay. Even before doing the biopsy, clinically, there can be a small clue to tell that it can be pemphigus. What is that small clue? You apply pressure on a normal appearing epithelium. That means that now patient's buccal mucosa you see here. Only this area is having that red erosions. This area is clinically appearing normal, right? Now this normal appearing area, you apply lateral pressure on that using your finger. So what will happen if you apply pressure there? There will be peeling away of the epithelium. That epithelium in that area will peel off. This is what you call as Nikolsky sign, and Nikolsky sign is positive in pemphigus. So clinically, even before you do the biopsy, there is one clue to tell you that this may be a pemphigus. What is that clue? A positive Nikolsky sign, that is applying lateral pressure on a normal appearing mucosa or skin. Even it can be on the skin, need not be always on the mucosa. Normal appearing skin or oral mucosa, there is peeling away of epithelium, and that is a positive Nikolsky sign, which is usually seen in pemphigus. There are different variants of pemphigus, like Pemphigus vulgaris, Pemphigus vegetans, foliaceus, erythematosus. Vulgaris is the most common one that you see, Pemphigus vulgaris. So there are minor modifications in the clinical appearance, but the histopathological feature will be similar for all these diseases. That is, you have an intraepithelial split or suprabasilar split along with acantholytic Zang cells. Now, there is one small problem here. Clinically, you had a vesiculobullous lesion. Histopathologically, you had Zang cells and intraepithelial split. Can you always confirm that it is pemphigus? Around 80% of the time, it will be pemphigus. But 20% of the time, there is a chance that it cannot be pemphigus, but it can be some other disease. So what is the other disease which will clinically have a vesiculobullous appearance and histopathologically show Zang cells and intraepithelial split, but it is not Pemphigus vulgaris? That disease is what you called as Hailey-Hailey disease. Now, what is this Hailey-Hailey disease? Hailey-Hailey disease was originally called as benign familial pemphigus. Don't think it is a type of pemphigus. No, it is not a type of pemphigus. Why? Because this Hailey-Hailey disease is not an autoimmune disease. It is a genetic disease. Genetic disease means there is a mutation in a particular gene. Because of that, you get the disease. That's why you call it genetic disease. Why it was called as benign familial pemphigus? Because clinically and histopathologically, it resembled pemphigus. So they called it benign familial pemphigus. It was first described by a person called Haley. So it is called Hailey-Hailey disease. So this disease, Hailey-Hailey disease, has almost all the features similar to pemphigus, but it is not pemphigus because the etiology is different. Hailey-Hailey disease is a genetic disease. Pemphigus vulgaris is an autoimmune disease. So how will you differentiate? Or in other words, how do you confirm that whatever you're seeing is only Pemphigus vulgaris? You have to do the next step, another investigation that's called immunofluorescence. So I'm not going into the technical details of that. Just understand that there are two types of immunofluorescence, direct and indirect immunofluorescence. What are you detecting in this test is that you are detecting the autoantibody. If Pemphigus vulgaris is an autoimmune disease, you will be able to see autoantibodies in the patient. You are going to identify that autoantibody against what? Desmoglein 1 and 3. Those autoantibodies are seen in two locations in the patient. One is in the tissue. Tissue means if patient is having lesion in the buccal mucosa, their autoantibodies are present. That is why you see a lesion there, correct? So you see it in the tissue. Number two, you also see it in the blood. Okay, so if you have to identify the autoantibodies in the tissue, like buccal mucosa, skin or labial mucosa, then you will do direct immunofluorescence. If you want to identify the autoantibodies in the blood of the patient, then you will do indirect immunofluorescence. That's the main difference. That much you understand. So by doing this immunofluorescence, whether direct or indirect, you are able to identify the autoantibodies. If you are identifying the autoantibodies, which means that it is an autoimmune disease. In Hailey-Hailey disease, immunofluorescent test will be negative, which means that it is not an autoimmune disease. You are not seeing any autoantibodies in that disease. So the confirmatory test for any autoimmune disease is to detect the autoantibodies, and that is mainly done by direct and indirect immunofluorescence. Okay, so this is what you need to know about pemphigus. And please remember that Pemphigus vulgaris is the most common type of pemphigus. The picture I showed you in the oral mucosa, but you also see vesicles and bulla on the skin because it's a mucocutaneous disease. Fine. Now we will move on to the second autoimmune disease that's called pemphigoid. So it's called pemphigoid because it is resembling pemphigus. Okay, you have two types of pemphigoid. One is cicatricial pemphigoid. That's what you're seeing in the screen there. And the second type of pemphigoid is called bullous pemphigoid. So what clinically, how cicatricial and bullous pemphigoid is going to be seen, that is also vesiculobullous lesion. So which means that like pemphigus, even in cicatricial and bullous pemphigoid, patient will have vesicles and bulla on the skin, as well as in the oral cavity. So all these three diseases, pemphigus, cicatricial pemphigoid, bullous pemphigoid, are clinically similar because they are all vesiculobullous lesion. Vesicles and bulla will be seen both on the skin and in the oral cavity. But there will be some small differentiating features, right? What are those differentiating features? First, talking about cicatricial pemphigoid. In addition to the oral mucosa, I have also shown picture of the eye. So that itself will tell you, in addition to skin and oral cavity, in cicatricial pemphigoid, patient also has involvement of the conjunctiva and the eyes. So vesiculobullous lesions will occur in the conjunctiva in these patients. So conjunctival mucosa is also involved here. That's the first difference. Second difference is that the term cicatrix, why is it called cicatricial pemphigoid? Because the term cicatrix means scar. So in this particular disease, there is vesicle and bulla formation that ruptures, erosion and ulcers are formed. That will heal, right? After some time, it has to heal. When it heals with scar formation, especially on the skin and in the conjunctiva. In oral cavity, you don't see that much of scar formation, but on the skin and in the conjunctival mucosa, you get scar formation. As a result of scar formation, patient may lose the eyesight also. So it's very dangerous. So cicatricial pemphigoid is a more serious form of the disease because in addition to skin and oral mucosa, conjunctival mucosa is involved. And the second one is the lesions heal with scar formation. Otherwise, it's basically a vesiculobullous lesion. What about bullous pemphigoid? Bullous pemphigoid, you don't see conjunctival mucosa involvement. You only see skin and oral mucosa involvement. And second thing is, there is no scar formation there. So when you have to differentiate between cicatricial pemphigoid and bullous pemphigoid, you have to differentiate based on two features. One is involvement of the conjunctival mucosa and presence of scar formation during healing, which both of which is seen in cicatricial pemphigoid, but it is not seen in bullous pemphigoid. But when you take a biopsy, histopathologically, what do you see? Whenever you see vesicle or bulla, histopathologically, that will reflect as a split formation, an empty area. So can you see in this picture that you see epithelium and connective tissue? The split is seen below the epithelium. So that's called subepithelial split. Whereas if you remember pemphigus, I told you it's an intraepithelial split within the epithelium. That's why, because you have autoantibodies against desmoglein 1 and 3, which is a component of desmosome. Because of that, acantholysis happens. All this is within the epithelium. That is why you see an intraepithelial split in pemphigus. Whereas in pemphigoid, you are seeing a subepithelial split, which means what? This is an autoimmune disease where autoantibodies are formed against laminin. Now go back to the first few slides I told you. What is laminin? Laminin is a protein present in the lamina lucida layer of the basal lamina, which means that autoantibodies are formed against laminin. Laminin is destroyed, which means the structure of basement membrane or basal lamina is destroyed. That is why you're seeing a subepithelial split here. Okay, so that is a very, very important differentiating feature between pemphigus and pemphigoid, because in pemphigus you see intraepithelial split, whereas in pemphigoid, whether it is cicatricial or bullous pemphigoid, you see subepithelial split, and all this can be appreciated only histopathologically. Clinically, you cannot see and tell whether it is intraepithelial split or subepithelial split. Clinically, all this is going to show vesiculobullous lesions only. Only by biopsy and histopathological examination, you will be able to appreciate the difference, that if you see a subepithelial split, then you will call it a pemphigoid. Again, bullous pemphigoid and cicatricial pemphigoid, both of it will have subepithelial split. How are you going to differentiate, or how do you confirm that it is cicatricial pemphigoid? You do immunofluorescence. Because if you do immunofluorescence, you will be able to detect the autoantibodies specifically against laminin. Then it is cicatricial pemphigoid. But if it is bullous pemphigoid, then you will see autoantibodies against a protein called BP230, BP180. What is that BP230 and 180? I never told you anything about it. They are nothing but they are components of hemidesmosome. Like how desmoglein is a component of desmosome. Similarly, BP230 and BP, this BP stands for bullous pemphigoid. BP230 and BP180 are proteins which are normal component of hemidesmosomes. Okay, you remember hemidesmosome is the junction that connects the basal cells to the basement membrane. That hemidesmosome is made up of BP 230 and 180 for all of us. Normally, every one of us have BP 230 and 180. But for all of us, it is normal. It is functioning properly. But in patients with bullous pemphigoid, autoantibodies are formed against this BP 230 and 180. See, these autoantibodies will destroy the hemidesmosomes. Therefore, the connection between the basal cells and the basement membrane is lost. That is why you see a subepithelial split there. So in case of bullous pemphigoid, see there, this is the histopathology. Just below the epithelium in the subepithelial layer, you are seeing that empty area. So this is called subepithelial split. So whether it is bullous pemphigoid or cicatricial pemphigoid, histopathologically will show the same feature, that is a subepithelial split. The differentiation can be made either using clinical features, that is not confirmatory, it will only give you a clue. The confirmation is by immunofluorescence, because by doing immunofluorescence, either direct or indirect, you are able to detect the autoantibodies which are specific to that particular disease. In case of cicatricial pemphigoid, these autoantibodies are against laminin, which is a component of basal lamina. Whereas in bullous pemphigoid, the autoantibodies are against BP 230 and BP 180, which are components of hemidesmosomes. Okay, this 230 and 180 is nothing but they are actually molecular weight of that protein. Okay, so BP 230 means that particular protein's molecular weight is 230 kilodalton. BP 180 means the molecular weight is 180 kilodalton. That is why the name is given as BP 230 and 180. Okay, so if I have to summarize all these three, pemphigus, cicatricial pemphigoid, bullous pemphigoid, all these three are autoimmune mucocutaneous diseases and vesiculobullous lesion, which means all of them have common etiology, autoimmunity. All of them produce disease on skin and oral mucosa or lesions of the oral mucosa and skin. And all of them clinically appear as vesicles or bulla. So that is common for all these three diseases. What is the differentiating feature? First differentiating feature is histopathology. So when you do biopsy and look under the microscope, pemphigus shows intraepithelial or more specifically suprabasilar split, that is within the epithelium, whereas cicatricial pemphigoid and bullous pemphigoid show subepithelial split just below the epithelium. That's the first difference. Second difference is that the autoantibodies in these diseases are different. They're all autoimmune, but autoantibodies are different. In pemphigus, the autoantibodies are against desmoglein 1 and 3, which is a component of desmosome. In cicatricial pemphigoid, autoantibodies are against laminin, which is a component of basal lamina. And in bullous pemphigoid, autoantibodies are against BP 230 and 180, which are actually components of hemidesmosome. So this is the difference you need to understand to differentiate these diseases. Now, all these three diseases are called localized autoimmune disease. Why are they called localized autoimmune disease? Because you're seeing the manifestation only on the skin and oral mucosa, sometimes in the conjunctival mucosa. You don't see involvement of the general systems. You don't see involvement of lungs, kidney, heart. No, only it is restricted to this oral mucosa, skin and conjunctival mucosa. That's all. But there are some autoimmune diseases which can show manifestation on the skin and the oral cavity. Along with that, it will also involve the systems of the body. Those are called systemic or generalized autoimmune diseases. Two of that diseases we are going to discuss today, which are important. One is called, I'll come back to this, SLE, systemic lupus erythematosus, and the second one is called systemic sclerosis. Now, please remember, both starts with S, systemic lupus erythematosus, systemic sclerosis. So both of these are autoimmune disease, that is no doubt about it. They show skin and oral manifestation, no doubt about it, but they are called systemic autoimmune disease because in addition to skin and oral mucosa, you have involvement of other systems. Okay, so now first about systemic lupus erythematosus. What is the skin manifestation, which is very characteristic? It is called as butterfly rash or mala rash. So what is the meaning of butterfly rash? See this patient. You have a red erythematous area on both sides cheek. These are connected by a redness on the bridge of the nose. So it will roughly resemble the shape of a butterfly, like how you see a butterfly, two wings of a butterfly, right? So that's called a butterfly rash or mala rash, which is very characteristic skin lesion that you see in systemic lupus erythematosus. In the oral cavity, you just see an erythematous area, redness, commonly seen in the gingiva. That's why that picture I put in this picture, commonly seen in the gingiva, sometimes in the hard palate. You see this patient, you see a red area in the hard palate. So the oral manifestation is nothing but an erythematous area, commonly seen either in the palate or gingiva. Skin, you see a butterfly rash or a malar rash. This is the skin and oral manifestation. In addition to that, these patients have involvement of the kidneys. Okay, they have proteinuria. Okay, they have involvement of the neurological system. They have involvement of the hematological system, resulting in anemia, leukopenia. So multiple systems are also involved. That is why the name systemic lupus erythematosus is given for this. Okay, so this is specifically skin and oral manifestation. There is another variant of SLE that's called DLE. DLE stands for Discoid lupus erythematosus. How is this different from SLE? In SLE, along with skin and oral mucosa, you have involvement of kidney, hematological, neurological systems also. But in DLE is a localized variant where you see only skin and oral cavity involvement. You don't see the systemic involvement in this disease. That's why it's called another name, given another name, Discoid lupus erythematosus. So how will the skin lesion look like? You don't have the butterfly rash here. You only have a single solitary lesion in the malar area. So you can see that there is a periphery red, peripheral area is red. The central area is having a silver scale, a kind of silver appearance is there. This is called discoid rash. So in SLE, you have malar rash, that's otherwise called butterfly rash. In discoid lupus erythematosus, DLE, you have something called discoid rash, which is totally different from a malar rash. Oral cavity, how is it? You have a red area, but the periphery of that red area is having a white border. See, please remember this picture very well. I'll tell you why it is important. Okay. In SLE, if you remember, you only saw a red area. Can you see that? In the skin also, it is only red area. Oral cavity also only red area. That much only is seen. But in DLE, in the oral cavity, you have a red area, but that red area peripherally is surrounded by a white border. Similarly, on the skin, you have a red area, but that is covered by a silver scale. Okay, so slightly different. That also you need to understand. So if you take biopsy, whether it is SLE or DLE, histopathology is going to be same only. Okay, that will not differ. So what will you see? You will see that you have an epithelium, you have a connective tissue here. The basal cells of the epithelium are destroyed by the autoantibodies. Okay, the basal cells are destroyed. That process is called basal cell degeneration. So you see a lot of lymphocytes here. These lymphocytes are destroying the basal cells. So basal cell degeneration. You see a lot of inflammatory cells here. The inflammatory cells are also surrounding the blood vessels. That's called perivascular appearance. Perivascular means surrounding the blood vessels. These blue dots, what you see are inflammatory cells. It can be a mixed inflammatory cell. It can be lymphocytes, eosinophils, mixed inflammatory cells. You see not only destroying the basal cells, but also surrounding the blood vessels. So that is the appearance, histological appearance of lupus erythematosus. Whether it is SLE or DLE, it is the same. So basal cell degeneration and presence of mixed inflammatory cells in the connective tissue are very characteristic features of lupus erythematosus. So I said this is also an autoimmune disease, but it's a systemic autoimmune disease. Therefore, what are the autoantibodies here? The autoantibodies are directed against the cell nuclear antigen. So within the cell, you have a lot of nuclear antigens. The autoantibodies are directed against it. Therefore, if you want to do a confirmatory diagnosis for lupus erythematosus, you can do immunofluorescence. And what will you detect in the immunofluorescence? Autoantibodies. What are those autoantibodies called as? Anti-double-stranded DNA. This is very, very important, because you should be knowing based on the clinical features. Oh, patient is having malar rash. Patient is having an erythematous area in the palate. There is involvement of kidney. Okay, there is involvement of hematological system. Maybe most probably this is SLE. Then you will ask them to get the indirect immunofluorescence done. From the blood of the patient, you will be able to detect autoantibodies. Those autoantibodies are called as anti-double-stranded DNA, which means against the DNA of the nucleus, the autoantibodies are formed. That is why it is called anti-double-stranded DNA. That is a very specific autoantibody detected in lupus erythematosus, which is the confirmatory diagnosis that it is lupus erythematosus. Fine. The next systemic disease is systemic sclerosis. So systemic sclerosis, the term sclerosis means that dense collagen fibers, hardness. Sclerosis means hardness. Why it is hard? There is some hard tissue that is formed. Why that hard tissue is formed? Because of dense collagen fibers. So basically, this is an autoimmune disease where dense collagen fibers are getting deposited throughout the body because it is systemic. It will be deposited in the skin, deposited in the oral mucosa. The dense collagen fibers will be deposited in the lungs, in the kidney, everywhere it will be deposited. That is why the term systemic sclerosis is given, because it's a systemic disease where dense collagen fiber is getting deposited throughout the body. So when excessive collagen fiber is getting deposited in the mouth, patient will have firmness of the mouth. So mouth opening will be very limited. Okay, microstomia means very small mouth. That is because excessive collagen fiber is getting deposited in the mouth. So this feature is almost similar to oral submucous fibrosis. If you all remember oral submucous fibrosis, that's a disease which occurs due to areca chewing. Patient will have difficulty in opening the mouth. Okay, so this oral manifestation of systemic sclerosis is also something similar to oral submucous fibrosis, because here also dense collagen fibers are deposited. The reason is different. In oral submucous fibrosis, the dense collagen fiber is because of areca chewing. And it is a potentially malignant disorder which can turn into a squamous cell carcinoma if it is not treated. Whereas systemic sclerosis, dense collagen fiber is deposited because of autoimmune cause. Autoantibodies are formed. These autoantibodies trigger the formation of dense collagen fibers. Now, this is one slight difference from other disease. In all the other autoimmune disease, whether it is Pemphigus, Pemphigoid, or systemic lupus erythematosus, the autoantibodies is causing destruction of tissue. Correct? Autoantibodies against desmoglein is causing destruction of desmosomes. That's why you see acantholytic cells. Whereas in systemic sclerosis, you have autoantibodies forming, but those autoantibodies are not causing destruction of cells and tissue. It is causing proliferation of collagen fiber. That is one slight difference between systemic sclerosis and other autoimmune diseases. Here you don't see any destruction, but you see excessive formation of collagen that is getting deposited in tissues, and because of that, you are seeing the damage. So in skin, if excessive collagen fiber is deposited, the skin will appear very firm. Okay, see this patient's mouth. It's looking like a mouse-like faces. Why it is called mouse-like faces? Because of dense collagen fiber in the skin, the patient's appearance is having with no expression. There is no expression on the face. This is called mouse-like faces. On the fingers and hands, excessive collagen is getting deposited. So there is a deformity in the hands and fingers. Can you all appreciate that? And also I told you there is deposition of collagen fibers in the lung. So pulmonary fibrosis will occur. There is deposition of collagen in the kidney. So renal fibrosis, all that is very dangerous. If you get pulmonary fibrosis, renal fibrosis, it will result in lung failure and kidney failure, and it will go to death of the patient. So this is also a very serious disorder. So if you do biopsy in the oral mucosa, what can you see? You will be able to see epithelium and connective tissue. The problem is in the connective tissue because you have dense collagen fibers in the connective tissue. You can see the pink area here. All these are dense collagen fibers in the connective tissue. So if you only see histopathological appearance, most of the time it will be similar to oral submucous fibrosis. You will see an epithelium. Below that epithelium in the connective tissue, you will see dense collagen fibers. So you will think that it is oral submucous fibrosis. So always remember, look for the habit of areca nut chewing. Only if patient is having areca nut chewing and then you have limited mouth opening, you can call it oral submucous fibrosis. If patient is not having any areca nut habit, but along with the limited mouth opening, if patient is also have firmness of the skin and also involvement of the organs, multiple systems, then you will call it systemic sclerosis. You have one small variant of systemic sclerosis where the systems are not involved, oral cavity is not involved, only skin will be affected. Only one area of skin will be affected. That is called scleroderma. Like how in SLE you had a variant called DLE. SLE means systemic lupus erythematosus. The variant of that is DLE, where you have only skin and oral cavity involvement. Similarly, systemic sclerosis is the name given if all the systems are involved along with skin and oral cavity. But scleroderma is the term given. It's a localized variant of systemic sclerosis where only skin is involved. Especially, you see the picture here, the skin in the midline of the forehead. Only this area there will be involvement. That disease is called scleroderma. Derma means skin. So only sclerosis of one area of the skin is seen. That's a variant of systemic sclerosis. Now this is looking like as if a scar is seen on the forehead. Clinically, when you look at it, you will think that there is some scar on this patient's forehead, right? It looks like that clinically. So this appearance is called as coupe de sabre. Coupe de sabre is a French word which means that strike with a sword, which means I take a sword or knife and I hit the patient will get a scar there, right? So it looks like that. So this appearance is called as coupe de sabre appearance, which is the clinical appearance of scleroderma, where you see a area of scar similar to, it is not scar formation, it looks like a scar formation in the midline of the forehead. Okay, that's a appearance of scleroderma. So that is one variant of systemic sclerosis. Now if you take a radiograph of the patient who is having systemic sclerosis, suppose you take a radiograph for some other reason, you will be able to appreciate one unique feature, which is a characteristic feature. What is that? There will be generalized widening of periodontal ligament space. What is this periodontal ligament space? Now, this is the tooth crown. This is the root. Root is lined by cementum. Next to that cementum, you see one white line, radiopaque line. That is lamina dura. What is the meaning of lamina dura? That's nothing but alveolar bone. That alveolar bone is seen as a white line, which is called radiographically called as lamina dura. Between lamina dura and the cementum, one black area is seen that represents the periodontal ligament. That's where the periodontal ligament is there. So that's called periodontal ligament space. Usually periodontal ligament is made up of collagen fibers. You all know that. Principal fibers of periodontal ligament are nothing but collagen fibers. So in this disease, systemic sclerosis, you have excessive or dense collagen fiber that is being formed. Therefore, radiographically, this PDL space will be widened. If you see the normal width of PDL space in a normal patient who is not having any disease, the normal width of PDL is somewhere between 0.17 to 0.17 to 3.5 mm. That's a normal range. But in patients with systemic sclerosis, there will be widening of the space. The space will increase, which you will be able to appreciate in a periapical radiograph. That is not with one single tooth. How many other teeth the patient is having, it is generalized widening of periodontal ligament space. This is an important viva question that you can be asked. Name the condition where you see generalized widening of periodontal ligament space in a radiograph. You cannot see widening of periodontal ligament space clinically. You look into the patient mouth, you cannot tell whether the PDL space is widened or not. No, you cannot do that. That can be appreciated only in a radiograph. So in a radiograph, if there is generalized widening means all the teeth will have same feature. Generalized widening of periodontal ligament space, always you have to think about systemic sclerosis. That is one important radiographic feature of systemic sclerosis. So to summarize, we have discussed about two systemic autoimmune diseases. One is SLE, systemic lupus erythematosus. The second one is systemic sclerosis. In systemic lupus erythematosus, you have malar rash on the skin, which is a butterfly-shaped rash, and erythematous lesion in the oral cavity, mainly in the gingiva and the palate. And there is a localized variant of SLE, where in addition to skin and oral cavity, in SLE, you have other system involvement, but in DLE, in discoid lupus erythematosus, you don't have other systems involved, only skin and oral cavity will be involved. That skin lesion is called discoid rash, and in the oral cavity, you have an erythematous area with a white border. That is the clinical appearance of oral lesion in discoid lupus erythematosus. And the autoantibodies that you specifically see in lupus erythematosus is anti-double-stranded DNA that is detected using immunofluorescence. In systemic sclerosis, there is deposition of collagen fibers. This is also due to autoimmune disease. So the autoantibodies are formed against a particular protein. These autoantibodies are called as anti-SCL70. SCL stands for sclerosis. So anti-SCL70, that is one antibody. The second antibody is anti-centromere antibodies. These are the two antibodies that is detected in patient with systemic sclerosis. I'll repeat once again, anti-SCL70 antibodies and anti-centromere antibodies are the two specific autoantibodies that you detect in patients with systemic sclerosis, where these autoantibodies do not cause destruction of the antigen, but they result in excessive deposition of collagen. The collagen will get deposited on the skin, oral cavity, and all the lungs, kidneys, everywhere in the system. One variant of systemic sclerosis is scleroderma, where only the forehead of the skin of the forehead is involved. This appearance is called Cope de Saber because it is resembling a scar formation. Okay, so this is about systemic autoimmune disease. Now, last, we are moving to another one autoimmune disease. Why I decided to discuss this autoimmune disease separately is because slightly different, but it is important. That is lichen planus. So lichen planus is an autoimmune disease, no doubt about it. But why I am discussing this separately is here autoantibodies are not formed. Ma'am, then next question you will tell, ma'am, you are telling it is autoimmune disease and you are also telling one contradictory statement that autoantibodies will not be formed. Then how can you call it autoimmune disease? You can still call it autoimmune disease. For that, again, going back to the basics of normal immunity. If you all remember in your microbiology pathology, you would have studied about two types of immunity: humoral immunity, cell-mediated immunity. In humoral immunity only, antibodies will be formed. That is when antigen is entering. Suppose a bacteria is entering. Antibodies will form against the bacteria and these antibodies will destroy the bacteria. This kind of immunity where antibodies are formed by the B lymphocytes is called humoral immunity. Whereas you have another type of immunity called cell-mediated immunity. Let us take an example. Instead of bacteria, COVID or coronavirus is entering a human body. Now, you all know viruses are intracellular. So this coronavirus will enter into the pulmonary cells. It will enter into the lung cells because they can only survive inside the cell. So now how will our immune system tackle that? The virus is hiding very safely inside the cell. So how will my immune system detect that virus? It cannot specifically kill the virus because the virus is very, very cleverly hiding inside the cell. So what will my immune system do? My immune system will kill the cell itself. So which means for killing the virus, I am sacrificing my own cell for killing the virus. Therefore, my immune cells are destroying the virally infected lung cells. So what will cause this immunity? The T lymphocytes will cause the destruction of the virally infected cell. So it is called cell-mediated immunity. Therefore, in the human system, we have two major types of immunity. Humoral immunity, where antibodies are formed against the antigen, that is by the B lymphocytes. Whereas you have cell-mediated immunity, especially in viral infections, where the virus will go inside the cell. Therefore, the T lymphocytes will directly kill the cell itself to kill the virus because the virus cannot be targeted specifically. Now, all this time, whatever we were talking about, they're all autoimmune disease: Pemphigus, Pemphigoid, the systemic lupus erythematosus, systemic sclerosis. They're all autoimmune disease where autoantibodies are formed. Therefore, their humoral immune mechanism is getting activated. Whereas lichen planus is an autoimmune disease, but it is a cell-mediated autoimmune disease. Therefore, here T cells are getting active. Therefore, no autoantibody production you will see. You will see T lymphocytes which are getting activated and destroying the normal basal cells of the epithelium. Normally, T lymphocytes are supposed to destroy only virally infected cell, correct? But here in lichen planus patient, the cell is not virally infected. It's a normal cell, but the normal basal cells of the epithelium, those cells are attacked and destroyed by the T lymphocytes. Therefore, lichen planus is a cell-mediated autoimmune disease. No autoantibody production is seen there. Okay, so you have skin lesions and oral lesions. Skin lesion will typically appear as a papule. Papule means it's a solid lesion. It is not filled with fluid. Okay, papular lesions are seen on the skin, whereas in the oral cavity, you have 4 different types of lichen planus. One is called reticular type. The second one is called erosive type. The third one is called papular type. And the fourth one, very rare type, bullous type. So in the oral cavity, you have 4 different types. The most common is reticular. Reticular, you all would have seen. interlacing white striae. So you will have white color lines which are interconnected with each other. That appearance is called reticular lichen planus, commonly seen bilaterally in the buccal mucosa. That's a very classic presentation of oral reticular lichen planus, where patient will have bilaterally interlacing white striae, and then you call it reticular lichen planus. Erosive lichen planus is you have a red area, but the periphery of the red area you will have white striae. You can see the picture here. That's called erosive lichen planus. Papular variant is similar to the skin. Skin you see papules, right? Same way on the oral cavity also you can see papular variant. This is more commonly seen on the tongue. And the fourth variant, where I am not having the picture, is a very rare variant, that is a bullous variant. So only in bullous variant of lichen planus, you will see a bulla formation. So when someone asks you examples for vesiculobullous lesion in the viva or in the exam itself, you might get an essay of vesiculobullous lesion. First, you don't tell lichen planus. Many students have the tendency, when I ask, give some examples for lichen planus, first they will vesiculobullous lesion. If I ask a question like that, give examples for vesiculobullous lesion, the first answer many students will tell is lichen planus. It is not wrong, but you have only one rare variant of lichen planus which can have a bullous appearance. The most common appearance of lichen planus is reticular and erosive. So don't tell that as the answer. That should be told is pemphigus, cicatricial pemphigoid, bullous pemphigoid. All that can be told as an answer. Last answer you can give us lichen planus. That's called bullous lichen planus. So what I'm trying to tell is lichen planus is not predominantly a vesiculobullous lesion. No. It is predominantly appearing clinically as intraorally reticular or erosive type. You have one rare variant which can show bullous appearance. That's called bullous lichen planus. And second difference is lichen planus, as I already mentioned, is a cell-mediated autoimmune disease. Therefore, you don't see any autoantibodies. Therefore, there is no point in doing immunofluorescence for diagnosing lichen planus, because you will not be able to detect any autoantibodies here, because it is a cell-mediated disease. So histopathologically, so how is the diagnosis made? Clinical and histopathologically is more than enough. So when you take biopsy and histopathologically, what will you see? I already told you the T lymphocyte is destroying the normal basal cells. So the normal basal cell destruction is called basal cell degeneration, which means the basal cells are destroyed. What is destroying that? T lymphocyte. So these blue colored dots that you see are nothing but they are all T lymphocytes. So you see subepithelial just below the epithelium, subepithelial dense band of lymphocytes. These are the two diagnostic histopathological features of lichen planus. Number one, basal cell degeneration, that is destruction of the basal cell. The second feature is subepithelial dense band of T lymphocyte, which is causing that destruction. So these degenerated basal cells can be seen microscopically, and they are given one name. They are called civet bodies. You all would have read it in your textbook. Civet bodies. What are civet bodies? The degenerated basal cells are otherwise called as civet bodies. The other name for civet body is colloid bodies. Both are same. Okay. So you see basal cell degeneration. You see degenerated basal cells, which are called civet bodies or colloid bodies. And you also see thus subepithelial dense band of T lymphocytes, which are actually causing this basal cell degeneration. In the textbook, sometimes you get a description of sawtooth retiridge. So students are very, very enthused about this term, sawtooth retiridge. So whenever I ask, tell me the histopathology of lichen planus, first thing everyone will tell you sawtooth retiridge. Please remember that sawtooth retiridge is not a diagnostic feature of lichen planus, which means if you take 100 patients with lichen planus, you may see it in some cases, you may not see in some cases. That is not needed for diagnosing lichen planus. You may see it as an additional feature. Okay, that is because of the basal cell degeneration. Normally, the retiridges will have one U-shaped or test tube shaped appearance. Yes, so whenever the basal cells are degenerated or destroyed by the T lymphocyte, that U-shaped retiridge appearance will go, and you will get a sharp pointing retiridge that is called sawtooth retiridge. That is, if you have a saw, you would have seen that saw how it will look. It will have a inverted triangle appearance. Yes, that kind of appearance the retiridges will have. That is called sawtooth retiridge. That is because of basal cell degeneration. You may see it or you may not see it. That's not a diagnostic feature of lichen planus. For all this autoimmune disease, the treatment is steroid, because the immune system is getting activated, right? So you have to suppress the immune system. So you have to give immunosuppressants. So you will give either topical or systemic steroids. That is the treatment for all this autoimmune disease: pemphigus, pemphigoid, lichen planus, systemic lupus erythematosus. For everything, the treatment of choice is either topical or systemic steroids. Okay. So we have completed the autoimmune disease. Very, very important, very frequently asked essay question, viva question. Pemphigus can be asked as a essay. Lichen planus can be asked as a essay. Just remember the basic concepts. That is very, very important in answering, because suddenly when you look at it, everything will look similar. You will not know which histopathology is for which one, which clinical feature is for which disease. You will get confused. That is normal for undergraduate students. That is why I am not concentrating more on that. I am concentrating on the basic concepts, because if you understand that basic, why the disease is caused, automatically you will be able to remember the clinical features and histopathological features. So you have two groups of autoimmune diseases. One is localized, where only skin and mucosa is involved. The other one is systemic, where both skin, mucosa, as well as the other systems of the body are involved. Under localized autoimmune diseases, you have pemphigus, cicatricial pemphigoid, bullous pemphigoid, and lichen planus. Lichen planus is slightly different from the other three, because pemphigus and pemphigoid, they have auto-antibody production because humoral immune response is getting activated there. Whereas lichen planus is a cell-mediated autoimmune disease, so no auto-antibody formation is seen there. On the other hand, in systemic autoimmune diseases, we have two main diseases: systemic lupus erythematosus and systemic sclerosis. Okay, with this, we are completing autoimmune diseases. I'll quickly move on to the second group. That is, I said the second group is some immune abnormality is there, but it is not autoimmune. Some other immune abnormality, but the exact cause is not known. That is called immunologically mediated skin disease with unknown etiology. We have two diseases under that. First one is erythema multiforme. Again, this is very, very important question. Whenever I ask the students, name some autoimmune skin diseases, first thing they will tell is erythema multiforme. I am stressing again and again, erythema multiforme is not an autoimmune disease. But along with pemphigus and pemphigoid in the textbook, the next lesion that is given is erythema multiforme. Why did they give like that? That is because clinically, erythema multiforme can have vesiculobullous appearance. That is why along with pemphigus and pemphigoid, it is described. Please understand, erythema multiforme is not autoimmune. You don't see any antibody production there. Then what is the etiology? We don't know. The etiology is unknown. But only thing we know is some abnormal immune response is happening in the body. In response to what? Mainly due to drugs, or it can be due to herpes simplex infection. These are the two triggering factors. They are not etiology. Drug intake and herpes simplex infection, they are not etiology for erythema multiforme. Please understand, the etiology is not known. Only thing is, in response to the drug intake and herpes simplex infection, some patients may show abnormal immune response. So these two are considered to be triggering factors. That is erythema multiforme. As the name only suggests, multiforme means multiple forms, which means clinically, patient will have multiple different lesions. It can be vesicle, it can be bulla, it can be papule, it can be a nodule, or it can be a very characteristic lesion in the picture, bullseye lesion. What is bullseye lesion? You all would have made an omelette, right? Bullseye. If you make that omelette, the periphery will be white in color. The central area will be dark yellow. Then surrounding that, you will have a light yellow color, which means that concentric layers of different colors. That's called bullseye lesion. So you see this clinical picture here of the hand. The central area is dark brown. Then the surrounding area is red in color. Then the next line is pink in color. So this kind of lesion where you have concentric areas of multiple colors is called a bullseye lesion, which is one of the characteristic lesion seen in the skin of erythema multiforme patient. So the name itself is called multiforme because clinically patient may have so many different types of lesion: vesicle, bulla, bullseye lesion, papules, macules, nodules, any of it can occur. Okay. So that is very important about erythema multiforme. So vesiculobullous lesion is also one characteristic clinical appearance of erythema multiforme, but that is not the only manifestation. You can have other manifestations also. There are two types of erythema multiforme. Erythema multiforme minor and major. In erythema multiforme minor, only skin and oral cavity is involved. Along with skin and oral cavity, if genital mucosa and conjunctival mucosa is also affected, then you call it as erythema multiforme major, which is otherwise called Stevens-Johnson syndrome. So Stevens-Johnson syndrome can be a short note for you. So don't blink when a question is asked about Stevens-Johnson syndrome. It is nothing but the other name for erythema multiforme major. So you have skin lesions, oral lesions, genital lesions, and conjunctival lesions. So just remember, erythema multiforme, not an autoimmune disease, but it is an immunologically mediated disease of unknown etiology. Two triggering factors, either drug intake or herpes simplex infection. It's called multiforme because clinically multiple different lesions can occur. One characteristic or unique lesion is bullseye lesion. Two forms are there, minor and major. The second disease, which is immunologically mediated, is psoriasis. So this also, the exact etiology is not known. It's not an autoimmune disease. The exact etiology is not known. But what happens here is the epithelium is having high turnover rate. High turnover rate means you have oral epithelium, right? The epithelium from the basal layer will differentiate. It will become spinous layer. From spinous, it will differentiate and become granular layer. From granular layer, keratin is produced. This process is called epithelial turnover rate. There is a time for that. For example, in the gingiva, the time taken for this entire process is around 20 to 25 days. That is normal. But in patients with psoriasis, the turnover becomes very high, which means for every 4 to 5 days, the turnover will happen, which means what? The epithelial turnover is more. So excessive abnormal keratin is formed. That excessive abnormal keratin only is seen as white plaque or patches on the skin. Can you see that? That's very characteristic feature of psoriasis. White patch or plaque, silver scales kind of appearance. Characteristically, silver scale kind of appearance. Plaque or patch is seen on the skin and it is highly pruritic. Pruritic means itching. Okay. Oral lesions are very rare. You don't get it. It's predominantly a skin lesion. But if you have it, you see erythematous areas. You don't see this white patch kind of area in the oral cavity. Oral cavity mainly is erythematous, but in the skin, there is characteristic silver scales or white patches or plaques that you see. That's because of increased turnover rate of the epithelium. So again, like erythema multiforme, psoriasis is not autoimmune. The exact etiology is not known, but what we know about this disease is the epithelial turnover rate is increased. Okay, that much you understand about psoriasis. Then the third group of disease is called genodermatosis. So when will you call something genodermatosis? Geno means genetic disease, which means that a particular disease is occurring because of mutation in a particular gene. Then you call that type of disease as genetic disease. And if that shows manifestation on the skin or primarily affects the skin and oral cavity, then you call that group of diseases as genodermatosis. So genodermatosis is not a name of a disease, but it is a group of disease. You give that name to a group of disease where patient have manifestation on skin and the oral cavity, and the etiology for that is some kind of genetic mutation. Okay, so 4 such diseases I'm going to quickly discuss today. The most common and frequently asked in the exam is ectodermal dysplasia. So please remember, ectodermal dysplasia is a genetic disease. So which gene is mutated here? The name of the gene itself is called ED. ED stands for ectodermal dysplasia, ED gene. Okay, so because of the mutation of this gene, what happens is that all the structures that are embryologically derived from ectoderm go back to embryology. You have 3 germ layers: ectoderm, mesoderm, endoderm, right? There are some structures and tissues forming from ectoderm, some from mesoderm, and some from endoderm. So the structures that are embryologically formed from ectoderm are not formed properly. Why? Because of mutation in a particular gene. That gene name is ED gene. Okay, that's why the name of the disease is called ectodermal dysplasia. So what are the structures that are formed from ectoderm? Number 1, hair. Okay, hair is formed from that. Number 2, you have teeth. All the components of teeth are formed from ectoderm. Please remember that. So teeth are formed. That is why we are discussing about this disease, because teeth is affected. Okay, teeth is formed from that. Salivary glands are formed from that. The sweat glands and sebaceous glands. You remember in the skin I showed you, sweat glands, sebaceous glands, hair follicle, all these are formed from the ectoderm. Therefore, based on this, you yourself can think and tell what are the features of ectodermal dysplasia. The hair will be very thin and sparse. You see this patient? Thin and sparse hair. Not only the hair of the head, but even the eyebrows, eyelashes, They are all very minimal or absent. That's number one. Number two, teeth, intraorally. Some of the teeth may be absent. Even if the teeth are present, it will have abnormal conical shape. You can see from the picture here. So if the teeth, few teeth are absent, you call it hypodontia. But very rarely, all the teeth may be absent. It's very rare, but all the teeth may be absent in some patient. Then you call anodontia. But most commonly, only few teeth will be absent. Then you call hypodontia. That's the second feature. So the sebaceous gland is not formed properly. The skin will appear very dry. Okay. And sweat glands are not formed properly. So patient cannot have sweat mechanism. So you all know sweat mechanism is to control the body temperature. So if sweat is not happening properly, the body temperature will shoot up very high. That condition is called hyperthermia. It's a very dangerous condition. Okay. So the three characteristic feature of ectodermal dysplasia is hypodontia, absence of few teeth, hypotrichosis, very little or sparse hair. Okay. So hypodontia, less number of teeth, hypotrichosis, okay, less number of hair, and also patient is having dry skin, and not only dry skin, but the sweat glands are very less. So the sweat mechanism is not happening properly. So patient is having hyperthermia, that is increased body temperature. Sometimes salivary glands are also, some part of salivary glands are also formed from ectoderm. So even in this patients, because the salivary glands are not functioning properly, patient will have decreased salivary secretion, dry mouth, and xerostomia. That is also a feature of ectodermal dysplasia. So just remember what are the structures formed from ectoderm. Based on that, you can write the features. So this is a very frequently asked short note for you, ectodermal dysplasia. That's an example for genodermatosis. The second disease, again frequently asked for you as short note, white spongy nevus. So white spongy nevus, the name only tells you white, because clinically the lesion appears as white in color. Spongy. Okay. So you see, classically the patient is having white, plaques on the buccal mucosa. Most of the time it is bilaterally seen, sometimes unilaterally. Buccal mucosa is the commonly affected side as shown in the picture, but sometimes you can also see involvement of labial mucosa. So very classically, white plaques will be seen bilaterally on the buccal mucosa. So what is the gene that is affected here? This is a genodermatosis. The gene affected is keratin. So the epithelium, stratified squamous epithelium of the oral cavity, the normal function of squamous epithelium is to produce keratin. That keratin only you are seeing superficially. Parakeratin, orthokeratin, whatever you are seeing on the superficial layer, they are all the keratin that is produced by the epithelial cells. That's the normal function of the squamous epithelial cell. But here in this patient, this keratin gene itself is mutated. So abnormal keratin is formed. This abnormal keratin only is seen as a white plaque here. So always remember, clinically, keratin will appear as white areas. Okay, whenever you dip your hand, try dipping your hand in a bowl of water for 10 minutes. You remove it and see. You will feel that your hand has become very soggy and white in color. That's because that keratin is getting deposited on the surface. So always, when keratin becomes wet, when keratin is seen in the oral cavity, it will be seen white in color. That's because of it is mixing with saliva and it is getting wet. That is why you see that white appearance. So this white spongy nevus is a genodermatosis characterized by mutation in keratin gene. Therefore, abnormal keratin is formed here. That is why clinically you see white plaques usually bilaterally in the buccal mucosa. So if you take biopsy, what will you see? You will see hyperkeratosis. Hyperkeratosis means excessive abnormal keratin is formed here. And even within the spinous layer, this excessive keratin can be seen as a pink area within the cytoplasm of the cell. So these are all some of the normal cells. But see these cells here on the right side of the picture. You see that pink, dark pink cytoplasm. That is because the abnormal keratin is getting deposited within the cytoplasm, and that is what is shown histopathologically here. So just to summarize, it is a genodermatosis where keratin gene is mutated. So the abnormal keratin is formed, which is clinically seen as a white plaque and histopathologically seen either as abnormal keratin on the superficial aspect of epithelium or within the epithelial cell itself, you will see a pink area. So keratin clinically will appear white in color. Histopathologically, everything will appear only pink and blue because we are using only two stains, right? Eosin and hematoxylin. So don't expect to see white area histopathologically. That white area, what I mentioned, is only clinically. it will appear, keratin will appear as white in color. Histopathologically, when you do a eosin and hematoxylin stain, always keratin will appear pink in color. So within the cell cytoplasm, you see pink areas that is representing the abnormal keratin here. Okay, that's the second disease, white spongy nevus. The third disease is Darier's disease. The other name for Darier's disease is keratosis follicularis. So again, here also, you have mutation in calcium channel. So this calcium pump is helping in normal production of keratin. So if the calcium pump is mutated, normal keratin formation will be affected. Therefore, that is why the disease name is keratosis follicularis. Here also some abnormal keratin is formed. That is not because of the keratin gene, but that is because of the calcium pump which is controlling the keratin gene. So Darier's disease is the genodermatosis characterized by mutation in calcium pump that controls the keratin protein. So skin, you will have a different appearance. Oral mucosa, you will have different appearance. In the skin, you can see multiple papules. And crusting you can see. And you see that yellowish white crusting that you see, that's all the abnormal keratin plugging that you see on the surface. So you will have multiple papules on the skin with the surface crusting that is representing abnormal keratin. Intraorally, you will see again multiple papules. Can you see this is one papule, this is another papule. So here also you see multiple papules. So when you have multiple papules, when you feel with your tongue, you will feel an irregularity, right? So this appearance where you have multiple papules in the oral cavity is described as cobblestone appearance. Cobblestone means you go to the seaside, you see a lot of stones there. So all that will have a smooth surface, but some kind of elevation, right? Same way, patient in Darier's disease intraorally is having multiple papules. So these papules will give an appearance called cobblestone appearance. Okay. There are few other diseases which can have cobblestone appearance of the oral mucosa. So just for you to know, I'm just telling that is no way connected to skin diseases or genodermatosis. But if a patient is having multiple papules in the oral cavity, that appearance can be described as cobblestone appearance, which can be seen in Darier's disease. It is also seen in one another disease. That disease is called as ulcerative colitis. Okay, you have a disease called ulcerative colitis. It's primarily a disease of the colon, inflammation of the colon. In that disease, oral manifestation, you can see cobblestone appearance. Just remember that for viva's sake, I am telling you. Ulcerative colitis is another disease where patient can have cobblestone appearance of the oral cavity, similar to Darier's disease. So I said that abnormal keratin is formed, right? That abnormal keratin is because of mutation in calcium pump, which is controlling the keratin. So these cells, the epithelial cells, which are having this abnormal keratin, two types of cells can be described here. Corprons, grains. So what is the meaning of corprons? Corprons means round bodies. So usually the cells of the epithelium will be polygonal in shape. But in Darier's disease, the cell is becoming round and accumulating the abnormal keratin within it. That round appearing epithelial cell is called corprons, round bodies. And some of the epithelial cells will become elongated. It will look like a grain, like a wheat or a rice, no? An elongated grain. That's how some epithelial cells will become. Those elongated epithelial cells are called grains. So corprons and grains represent the abnormal morphology of the epithelial cell. Corprons means round bodies. Grains means elongated cell resembling a grain. Okay, these are the histopathological features of Darier's disease, and these two cells represent the abnormal cells which have an abnormal keratin within it. The last disease, which comes under genodermatosis, again very, very important for you, for viva point as well as for theoretical point, Ehlers-Danlos syndrome. So this Ehlers-Danlos syndrome, you have mutation in collagen gene. So in ectodermal dysplasia, the gene that was mutated was called ED1. ED stands for ectodermal dysplasia, which means that gene is controlling the formation of structures derived from ectoderm. So all the structures derived from ectoderm were affected in that. Whereas in white spongy nevus, there is a mutation in keratin gene. So abnormal keratin is getting accumulated. That's why you see white plaques clinically. In Darier's disease, you have mutation of calcium pump that is again controlling the keratin gene. So again, you have abnormal keratin there and cells getting accumulated there. Whereas in Ehlers-Danlos syndrome, the problem is not in the epithelium. The problem is in the connective tissue, which means the collagen gene is mutated in Ehlers-Danlos syndrome. You have 8 different types of Ehlers-Danlos syndrome. In each type, different type of collagen are affected. So now you understand that in human body, you have 19 different types of collagen. Each type of collagen is seen in different areas. For example, in oral mucosa, in the lamina propria, you see collagen, that is type 1. In periodontal ligament, you see collagen, that is predominantly type 1 and some type 13 is seen. I said in basement membrane, lamina densa, you have type 4 collagen, right? So in different areas of the human body, different types of collagen are seen. So each collagen is mutated, then different types of disease occurs. So the clinical manifestation also will be slightly different, but all the types, the common mutation is some type of collagen is mutated. Therefore, this Ehlers-Danlos syndrome is also called as a collagen disorder because collagen is mutated here. So what are the common symptoms and signs seen in all forms? In each form, slight variation is there. We are not going into that. The common features for all the forms. Because collagen is mutated, here patient will have increased elasticity of the skin. You see this picture here. This girl is able to pinch the skin and pull it out like that, which means that the skin is also having collagen. So there will be increased elasticity of the skin. That is number 1. The joints are having collagen. So the patient is having hyperextensibility of the joints. See, he is able to bend his finger like that. We will not be able to do like that. Correct. But this patient is able to do because of the hyper flexibility and extensibility of the joints. That is another feature there. And easy bruising. Easy bruising means even in a small minor trauma, you go and get hit yourself in the corner of the chair when you're walking. There one big bruise or hematoma will form. That is because the walls of the blood vessel is containing collagen. So that will be damaged. So very easily the blood vessels can also be damaged. So the 3 most common findings in Ehlers-Danlos syndrome, which is common for all forms of Ehlers-Danlos syndrome, is hyperextensibility of the skin, hyperextensibility and flexibility of the joints, easy bruising even in minor trauma or friction. That is because involvement of the blood vessels. In oral cavity, what is a characteristic manifestation here is the patient will be able to touch the tip of the nose with the tip of the tongue. You all try doing it, whether you are able to touch. I don't think so. Any one of you or most of you will not be able to do it, because you have a restriction for the movement of the tongue. But in patients with Ehlers-Danlos syndrome, these patients will be able to touch the tip of the nose with the tip of the tongue. That is because of extensibility. Okay. This is called Gorlin sign. So Viva question, note it down. What is Gorlin sign? Gorlin sign is seen in patients with Ehlers-Danlos syndrome, where the patient will be able to touch the tip of the nose, not with the finger, but with the tip of the tongue. Okay. Because of this extensibility and hyper flexibility, the other name for this syndrome is called rubber man syndrome. If you would have watched circus, in circus and in many exhibition shows, there will be some people who can bend and do multiple kind of yogas and positions. They will be able to do. They have good acrobatics, who have good flexibility. Okay, they may be having some form of, I'm not telling all the people who are having that flexibility have Ehlers-Danlos syndrome. That is not what I'm trying to say, but that extreme form of this is what is called Ehlers-Danlos syndrome. So the other name for this syndrome is rubber man syndrome. So the question can be asked as rubber man syndrome. Don't blink. It is nothing but it's Ehlers-Danlos syndrome. Just mention it is a collagen disorder. You have 8 different types. Different type of collagen is mutated in this disease. But the common symptom is hyperextension of the skin, hyperflexibility and extension of the joint, and easy bruisability. So where all collagen is seen, all those areas will be affected. Skin will be affected. Oral mucosa will be affected. Blood vessels will be affected. Periodontal ligament can be affected. Basement membrane can be affected. Joints, cartilage, bone, all these areas have collagen. So all these areas can be affected in Ehlers-Danlos syndrome. Okay. So Gorlin sign is what you have to keep in mind. So do not confuse this Gorlin sign with Gorlin cyst. Gorlin cyst is the other name for calcifying odontogenic cyst. The names all sounding similar. Just for differentiation, I am mentioning here. Gorlin sign is touching the tip of the nose with the tip of the tongue, which is positive in Ehlers-Danlos syndrome. Gorlin cyst is the other name for calcifying odontogenic cyst. It's an example for an odontogenic cyst. You have Gorlin-Gott syndrome. That is a syndrome characterized by multiple odontogenic keratocysts. That is totally different. All this is having the name Gorlin within it. So don't get confused. Gorlin sign is different. Gorlin cyst is different. Gorlin-Gott syndrome is different. Okay. So with this, we come to the end of the session. It's a very big topic, huge topic. So within this time, it is very difficult for me to tell everything that is given in the textbook. So what I have tried to do is I have only focused on very important diseases that is frequently asked as a essay or a short note for you in the theory exam. I've checked the question papers and based on that. So please remember pemphigus, lichen planus, white spongy nevus, ectodermal dysplasia, Danlo syndrome, erythema multiforme, all these are very, very frequently asked questions for you in the exam. Try to understand the concept, what each of this means. What is an autoimmune disease? What is a genodermatosis? And what is the immunologically mediated disease, but it is not autoimmune? So these three differences you try to understand. Based on that, you yourself can write the clinical features. It is very simple as that. Okay. So I also try to focus to put the pictures. I didn't write anything because I want you to at least remember these pictures. So, you know, humans have this tendency of remembering pictures, photos. So I tried to put that photo. So at least you will remember that picture and, you know, you will try to reproduce it in your exams. So if there are no other doubts, I think Dr. Jopi, we can.
Yes, ma'am. Thank you so much, ma'am. Thank you so much. Yes, students, if you have any more doubts, you can put. Otherwise, we can call it a day. Thank you so much. That was an amazing time, ma'am. You explained it with pictures, and it is so amazing. People can remember in the sleep also they can remember. So we have any more questions? Very nice lecture, ma'am. Thank you so much, Pasumati Reddy. If any more, please, you can put your feedback on the chat box. We can give you another 2 to 3 minutes. That's it, because already time is passed. If it's any question is there. Treatment of immunological mediated disease, ma'am. Treatment of immunological mediated disease.
You can for erythema multiforme, you know, most of the time it's triggered by drugs. So you have to identify whether you have to ask the history from the patient and identify whether there is any drug intake. Try to stop that offending drug, and you can give steroids for them because it is basically only to control that exaggerated immune response. But in case of psoriasis, steroids will not help because here there is epithelial turnover rate is high. So you have to do something to decrease the turnover rate. Therefore, you have to give some keratinolytic agents to apply topically, and one thing called PUVA therapy. I think the name itself will tell you PUVA. PUVA therapy means you are applying topically a medication, then you are exciting with ultraviolet light A. Psoralen plus ultraviolet A. That is the full form of PUVA. PUVA means psoralen plus ultraviolet A. Psoralen is a medication. You apply that to the lesion and then you excite it with ultraviolet A ray. Then that lesions will disappear. That is the treatment for psoriasis. So steroids will not help for psoriasis. PUVA therapy is given. Otherwise, for erythema multiforme, stop the offending drug and you can give steroids for healing of the lesions.
Okay, ma'am. So another question from Himani is for classification. Should we follow standard book or any other book is fine, ma'am?
No, see, any classification, if it makes sense, it is okay. See, there are some standard classification for some lesions. For example, odontogenic cyst or odontogenic tumors. You cannot write your own classification because there is a standard accepted classification, WHO classification, current classification given in 2017. So you are expected as a student to write only that. Similarly, if you have, vesiculobullous lesion, there is no standard classification for that. So if any classification that includes all the possible lesions and which makes sense, you can write it, nothing wrong in it. That is how I have classified skin diseases. This is not any standard classification, but it makes sense. It is based on etiology of the disease and it includes almost all the diseases. So you can definitely write that.
Okay, ma'am. Another question is Avarna that says, is bull's eye lesion in erythema multiforme is painful?
It's not painful. Okay. Actually, I have seen so many patients with erythema multiforme. It usually affects young adults, okay? You see multiple lesions. When you look at it, you will feel that, oh, this is so bad. This is looking so bad. But for the patient is not that much. In the oral cavity, it's different. Bullseye lesion occurs on the skin. That's not painful. But if it is in the oral cavity, any lesion in the oral cavity is comparatively painful. That's because, we have to keep eating food. We eat hot food, we drink hot coffees. So we eat and drink and we talk, right? Therefore, friction is more in the oral cavity. Therefore, lesions in the oral cavity tend to be more painful and produce discomfort compared to the lesions of the skin. But to answer your question, bullseye lesion is not painful.
From Roshni is treatment of rubberman syndrome.
Again, for all the genodermatosis, there is a mutation in the gene, right? So there is as such no treatment for that because you cannot change the gene. The gene is already there, and when you are born itself, you are born with the mutation in the gene. So you or me or any other doctor cannot correct it. Therefore, some symptomatic treatments can be given for that, but as such, the disease cannot be cured completely. Any of the genetic disease for that matter. Not only genodermatosis, any genetic disease, there is no complete or permanent cure for that. There are some genetic therapies which are under trial in foreign countries. People are just having trials for genetic engineering, genetic therapies, but that has not come into practice, especially in developing country like India. It's not come into practice. So as such, currently, we don't have any treatment for genodermatosis, any of those diseases.
Fine. Tirtha is asking question, is there any similarity between systemic sclerosis and multiple sclerosis? Even though they are different etiology, there is any
the name multiple sclerosis is an autoimmune disease. Okay. Multiple sclerosis is an autoimmune disease. That is the similarity between systemic sclerosis and multiple sclerosis. But the clinical features are totally different because multiple sclerosis is basically a demyelinating disease affecting the central nervous system. Okay, you have a lot of neurological symptoms there, and it's primarily affecting the central nervous system. Systemic sclerosis, and it does not affect the other systems of the body. So, in fact, multiple sclerosis is mainly called as a localized form of autoimmune disease only. Like Hashimoto's thyroiditis, where only thyroid gland is affected. Multiple sclerosis is localized autoimmune diseases affecting mainly the central nervous system. It is a demyelinating disease. It's an autoimmune disease. Systemic sclerosis, the common similarity between that and multiple sclerosis, both are autoimmune, but systemic sclerosis is more of a systemic disease affecting multiple systems of the body. That's the difference between these two.
And you already mentioned about genodermatosis. Only supportive treatment is there. There is no definite treatment or under trial.
Permanent cure is not available.
Okay. There is another question. I think it's not very clear why carcinoma treated by arsenicals or heavy metals.
I don't know what is the connection between that and today's topic, but I think that's a doubt that person genuinely has. If you, in previous, not now, very long back, historically, carcinomas, there's so many different types of treatments were tried, when proper treatment was not available in those days, so many years back. People used to try different types of treatment, and that's when heavy metals or arsenicals were used for treatment of different diseases. But currently now, we know that those kind of treatments don't work for carcinoma, especially oral squamous cell carcinoma in the oral cavity is treated primarily by surgery or radiotherapy. That's the accepted and standard treatment followed now. All these, whatever has been given in the textbook, all these are historical treatments. Now no one uses it. It's all out of question now.
Right. And one more question is Divyasri is what are the drugs that specifically trigger erythema multiforme?
You have, it is not one or two drugs. You have a set of around 10 to 15 group of drugs. The most common ones are NSAIDs. See, we will not even imagine, because that in and out as dentists, we all prescribe NSAID, non-steroidal anti-inflammatory drugs. Like for tooth pain, we give that to the patient. Many of these NSAIDs actually trigger erythema multiforme. The patients I have seen come with patients who have taken antibiotics or NSAIDs, and they have got this erythema multiforme. And anti-HIV medications, they can cause Stevens-Johnson syndrome. Okay, so it is not one single drug. Multiple groups of drugs are there. To mention very common ones and most frequently used ones are NSAIDs, antibiotics, and anti-HIV medications.
Right. Roshni says one more question. Can these skin diseases get converted into cancer?
Not all of them. You have a group of disease which can get converted. The ones which I mentioned, none of these will get converted to cancer. But you have a very rare disease, which I have not mentioned in today's lecture, dyskeratosis congenita. Okay, that has a tendency to turn into cancer. So that is considered to be a potentially malignant disorder. Okay, but that is not very common in the oral cavity, and it is not important for undergraduate students. And because of lack of time, I didn't discuss that. But Discoid congenita is an example for genodermatosis, and that disease has a potential to turn into cancer.
Okay. The last question of the day is, what type of biopsy usually done for autoimmune disease?
First, always incisional biopsy only, it needs to be done, because surgery is not the treatment for autoimmune diseases, right? The purpose of doing the biopsy is just for diagnosis. So a simple incisional biopsy is more than enough. Some cases, even you can take a smear also. If you have a vesicle, an intact vesicle, you can take a smear of the vesicle fluid. Even no need to do biopsy also. In the skin or in the oral cavity, you can do a smear. Even in the smear, you will be able to appreciate that acantholytic Zang cells. That is only for Pemphigus. But in case of Cicatricial and Bullous Pemphigoid, we need to appreciate the subepithelial split, right? So in that case, smear will not help. You have to go for incisional biopsy.
Okay, ma'am. There's one more question. One student has requested, ma'am, what is blue tooth or teeth disease? Can you please tell?
As far as I know, you can have a blue tinge or blue discoloration of tooth in a condition called dentinogenesis imperfecta, where there are so many diseases where the color of the tooth will change. You can get an yellow color teeth or brown color, red color, blue color. So if I'm not wrong, if that is what he or she is mentioning, I think it is Himani. So she is mentioning blue tooth, maybe. Most probably it is referring to bluish discoloration of the tooth that usually occurs in a developmental condition called dentinogenesis imperfecta.
Maybe she meant that Bradywine type, that there are types of dentinogenesis.
Yeah, different types of dentinogenesis imperfecta where you can clinically see a blue color tooth. So yes, maybe in an exam paper somewhere they would have asked a question called blue tooth. I think they will not know what it is. Most probably they are referring to dentinogenesis imperfecta.
Fine, ma'am. Fine. Thank you so much, ma'am. So amazing and so nice to listen to your lectures, are very crisp and clear. Thank you. All the candidates, please do refer. Thank you so much. Please appreciate and put your critical analysis about how was the lecture in your WhatsApp group. And thank you so much, ma'am. It was a hectic day. You started 7:30.
It's a pleasure. It's a pleasure, coming here and telling the students whatever little I know. If they are benefited and they have understood the lecture and that outcome, whatever the idea why we started this exam alert itself is for the benefit of these students. So at least in some way, if they are benefited, I am so happy and glad I could spend this time for them. And thank you, Online Dentistry, for giving me this wonderful opportunity to interact with these kids. Looking forward to more sessions like this.
Definitely, ma'am. Definitely, we'll plan, ma'am. We'll plan. Even exams are coming up, so we can have a exam-oriented session.
Session also, yes. Because I just focused mainly on undergraduates for their exam point of view. I didn't want to unnecessarily take like a routine lecture telling all the lesions. It's no use, right? So
we'll plan, ma'am. We'll definitely plan, ma'am. Thank you so much, ma'am. Good night. Good night, all.
And all of you, thank you for coming today and making it interactive. Thank you all and best wish and good luck for your exams.
Thank you.
Bye-bye.